Welcome to my channel. Try to boost your mind and answer first just by looking at the picture, and then compare your answer with my answer. Arrhythmogenic right ventricular cardiomyopathy/dysplasia, ARVC/D, is a heart muscle disease that primarily affects the right ventricle. It's characterized by the replacement of heart muscle with fatty and fibrous tissue, which can lead to arrhythmias, particularly ventricular tachycardia, VT. Here's a breakdown of the ECG findings associated with ARVC/D. Key ECG features. T-wave inversions. This is a common finding, especially in the right precordial leads, V1, V3. These T-wave inversions reflect abnormalities in repolarization. Epsilon wave. This is a small, positive deflection that occurs after the QRS complex. It's a relatively specific but not always present marker of ARVC/D. It can be subtle and difficult to detect. Ventricular tachycardia, VT. ARVC/D can cause VT, which typically has a left bundle branch block, LBBB. Morphology. This morphology indicates that the VT originates from the right ventricle. Prolonged S-wave upstroke. A prolonged S-wave upstroke in the right precordial leads has been shown to be a fairly sensitive marker. Other ECG changes. Right ventricular conduction delays. QRS widening in the right precordial leads. Hypokalemia, a condition characterized by low potassium levels in the blood, can significantly impact the heart's electrical activity, leading to various ECG changes. Here's a breakdown of the ECG findings associated with hypokalemia. ECG changes associated with hypokalemia. T-wave changes. Flattening or inversion of T-waves. This is often one of the earliest signs. Decreased T-wave amplitude. U-waves. Prominent U-waves. These are positive deflections that follow the T-wave. They are particularly noticeable in the precordial leads, V2, V4. Saint segment depression. The ST segment may become depressed. Prolonged QT/QU interval. The U-wave can merge with the T-wave, creating an apparent prolongation of the QT interval, which is more accurately described as a prolonged QU interval. Other potential changes. Increased P-wave amplitude. Prolongation of the PR interval. In severe cases, hypokalemia can lead to arrhythmias, including ventricular tachycardia, ventricular fibrillation,
torsade de pointe.
Wolff-Parkinson-White, WPW syndrome is a condition characterized by an extra electrical pathway between the atria and ventricles of the heart. This accessory pathway can lead to a type of arrhythmia called supraventricular tachycardia, SVT. The hallmark of WPW on an electrocardiogram, ECG, involves specific changes. Here's a breakdown of the key ECG findings in WPW. Short PR interval. The PR interval, which represents the time it takes for electrical impulses to travel from the atria to the ventricles, is shortened, less than 120 milliseconds. This is because the accessory pathway bypasses the normal delay that occurs in the AV node. Delta wave. This is a slurred upstroke of the QRS complex. It represents the early activation of the ventricles through the accessory pathway. Widened QRS complex. The QRS complex, which represents ventricular depolarization, is widened, greater than 120 milliseconds, due to the fusion of the normal ventricular activation and the early activation through the accessory pathway. Secondary STT wave changes. These are repolarization abnormalities that are often seen in WPW. They are typically opposite in direction to the delta wave and QRS complex. Thank you for watching my video. To learn more about TOACS, please stay tuned and don't forget to like and subscribe.